आज के टुटेजा टॉक शो में डॉक्टर राजीव सेठ, पास्ट वाइस प्रेसिडेंट IIP, very active against the sexual abuse and in favor of treating street children, is going to talk to us and will update us.
Thank you, sir.
Dr. Rajeev Seth is MD from AIMS, DNB, FIAP, FAAP from USA, Medical Director, Child Health Development Center, Delhi National Coordinator, IIP Prevention of Violence Against Children, PVAC Initiative, Past Chair, Indian Child Abuse, Neglect and Child Labor Group, and Spokane, USA. You are most welcome, sir, and you can start your talk and share your slides.
Thank you. Yeah. Sir, can you see my slides?
Yes, sir.
Okay, sir. Thank you for this opportunity, Dr. Tuteja, for giving me this opportunity. We are going to discuss street and working children, and we are going to discuss how we can optimize their health, well-being, and realize rights for these underprivileged children. This is uh, uh, not my own work. This is a credit goes to number of societies which I worked, including our own Indian Academy of Pediatrics, the Indian Council Group, the International Society for Prevention of Child Abuse, the International Society for Social Pediatrics and Child Health, the Johns Hopkins Institute, the International Pediatric Association, who gave us an opportunity in 2023, and BUDS, and two NGOs, CINI and BUDS. So I'll now proceed with my talk with just simple definition of street children today. Uh, this is by the United Nations Committee on the Rights of Children. These children are defined as those children who depend on the streets to live and work, whether alone or with peers or with family, as well as if they also are a wider population of children who have formed strong connections with public spaces and for whom the street plays a very vital role in everyday life and their identities. Now, why do we want to talk about street and working children? Firstly, the scale of the problem is huge and there are many common drivers. It's both a very important human rights violation and also a major public health problem. The estimates and the data of these children is mostly hidden and not available readily. It occurs globally. People think that only the low middle income countries have street children. That is quite far from truth. Today, even the high income countries like the US and the European countries have populations of street children. Poverty and violence in families are major contributors for development of street children. And most of these children have disruptions in their education. We are very happy that Lancet Global uh, um, introduced this topic in the form of an editorial post our IPA and IAP workshop at Gandhinagar during the Paddycon 2023. Now, the Consortium of Street Children is a UK-based NGO which works globally on and you can see on the map, it's both a problem of the high income as well as low income countries. And in a study in Ludhiana in Punjab, the street children were spending more than 6 to 9 hours per day on the streets doing all kinds of jobs. If you look at the problem in South Asia, total estimates, NGO data says about 20 to 30 million children live on the streets. India has the highest number of street children, about 15 to 20 million, followed by other countries like Pakistan, Bangladesh, Sri Lanka, and Nepal. So this is one of the first publications that our group, the Consortium of Street Children, I am humbly the co-chair of this group along with Professor Shanti Raman based in Sydney, Australia. And our group was able to start a global collection for street and working children in the British Medical Journal. In the opening viewpoint, which was published in the BMJ, said that the street and working children are those which are most vulnerable to violence, exploitation, exposure to toxic environments. It's extremely important that we prioritize the rights, health, and development of these children and create a better well being and future for these children and give them an opportunity so they can thrive. Now, child labor is a huge, big problem, and this has now recently, very recently, in June of 2025, the new data has come out. These global estimates of 2024, which were released by UNICEF and ILO, International Labor Organizations combined, showed that this problem is though persistent, but the numbers have declined to 138 million from the previous 160 million. Now, 54 million children out of these still work in areas which are called hazardous, which jeopardize their health, safety, and development. And for the last 4 years, this study has shown the world has returned to the path of progress. This is really heartening news, but we have a lot of work to do still in sub-Sahara Africa and parts of Asia. COVID-19 presented a huge big challenge, and also the majority of the children who are engaged in labor were found in rural areas, and agriculture being the most common form of labor. The labor also occurs in poorest of poor families within their homes, and frequently these children are out of school. Now, the health status, if you look at 108 papers that we were able to find online, and we found that the health status of street children has been studied sporadically, but a systemic review came up in Journal of Adolescent Health. And they found that boys were the most visible group, and they were all experiencing structural violence, poverty being a common, and family conflict and violence was very much common. These children have problems with nutrition, growth problems, infectious disease, sexual and reproductive health concerns, and violence due to multiple factors. Mental health concerns and substance abuse was also one of the most common topics in these. Now, one of our colleagues, Shoma MacLeod from UK, was able to publish this paper in BMJ, which showed that there are key barriers why these children are not able to access healthcare. One of the most common is cost. Other is failure to show their identity card. Many of these children in the streets in India do not have an Aadhaar card or any kind of an ID to show their identity. They are discriminated by healthcare providers. And many times when they go into the hospitals, they are not able to get access to quality care until and unless they are accompanied by the adult or a family member or a NGO representative. So these children do suffer from the hands of the healthcare professionals as well. The consortium of street children in UK has been able to show that the girls were more commonly seen to be exposed to sexual violence, commercial sexual exploitation, leading to pregnancy and sexually transmitted diseases. There were problems in the girls for menstrual hygiene, and they were not using sanitary products. The boys were exposed to other forms of violence, particularly substance misuse was very common. And then both genders had problems with mental health concerns and sexual violence. Now, if you go into this slide, this is a small non-profit organization, and I would like you to just have this look at this video for, say, about 2 or 3 minutes. Bal Umang Drish Sanstha. This is an Indian non-profit which was formed with the objective of providing well-being, health, education, and welfare. So this non-profit was established in 2023 based in New Delhi, and study from our partner organizations revealed that more than 13.7 million households in India are living in urban slum conditions with inadequate basic amenities, poor access to healthcare, poor health outcomes, and unstable incomes. These millions of slum dwellers, many didn't have any identity card or even had a birth certificate. They faced caste they each challenges, stigma and discrimination is rampant. And so we decided, how about we are able to go to them and provide healthcare through mobile health vans. This is nothing innovative about this. As you know, there are mobile health vans have existed before, but we wanted to do ourselves and see whether this becomes a proactive pathway for providing healthcare access to these marginalized street children. Now, mobile health van came through a CSR opportunity from PricewaterhouseCoopers Foundation, and we were able to utilize in our setting in Delhi and also in the neighboring state of Haryana. Now, there are studies, but very little studies have shown uh, whether they work. And therefore, after implementing this project from 2017 onwards till as of now, to date, we wanted to understand how our work is impacting, how it is making change in the lives of these children. So one of the aim was we wanted to study our data and particularly focus on the benefits to children in Delhi NCR. Our model is based on prevention of disease, from treatment and promotion of health, and we wanted to study all of this through a mixed method approach. This mixed method approach included two kinds of data. One was the quantitative data, which we studied between the times of June 2017 to December 2023, and a qualitative data, which included focus group discussions. Two of them, one was in a set of 18 mothers who used our mobile van, and the other was a mixed group of 12 adults whose children came. In-depth case studies were done of two children. One was Rafiq. His name has been changed. He's a 9-year migrant from Bihar who actually from Bihar went to Kolkata seeking help for his congenital heart disease. He had a major ventricular septal defect and it led to multiple episodes of bronchopneumonia. From Kolkata, this child was then transferred to Delhi, came to LNJP, and after 2 years there, they decided to send him to All India Institute till COVID broke out. So after about 7 years with no good care, he was first diagnosed with me in our mobile health van. And we were able to not only fast track his admission to a leading private hospital of Delhi, but he is symptom free, he's operated. Similarly, Sonia is a 15-year-old girl who came to know of the mobile health van while she was attending to education classes in the drop-in centers. She had active tuberculosis and which was treated in a local hospital. You look at this data, this is a huge number as you can see, and from 2017 and to 2023, the numbers have only progressively increased. In 2023, we were able to see more than 8,864 children. And out of all these, we made referrals to just under 10%. The development disabilities were identified in about another 10% children. Health education was provided to a large number of children. In fact, more than what we were able to provide access, they were done in the mobile health van. It was also done in the vicinity schools. So you see that this data is about more than 41,000 clinic visits for children under the age of 18, with maximum peaking of more than 8,864 patients by 2023, and just under 10% were referred to specialist care, and about 122 were diagnosed with disabilities, and health education was provided to more than 70,000 children. Now, when we looked into our qualitative, the focus group discussions, the two FGTs that we conducted, one with mothers and other with mixed group or adult participants, we came to know the following themes which emerged. One is that the mobile health van was able to enhance the access to health services. Earlier, we were spending the entire day waiting for our turn at a government hospital. We are very thankful to the community mobilizer, the NGO Buds, who informed us about mobile health van services in our community. Then the other said the health education provided by mobile health van is very helpful for us as it prevents diseases. And the doctor spoke very politely. I felt like half the disease is gone. Then there was something about the value. They says mobile health van helped my child continue her studies, and at the same time she received a treatment whenever she was not well. The more than 70,000 children who provided health education sessions, ranging from early childhood, such as breastfeeding, early childhood development, immunizations, to infections of the day, such as influenza, dengue, and during COVID, it was COVID education, nutrition, healthy lifestyles, disease prevention, health, and sanitation. Now we conclude from this is that the mobile health van clinics take healthcare to the doorsteps of street children and includes those children who are uninsured and undocumented. This is a major plus because here these children are sometimes not able to access quality healthcare in major hospitals, both uh, they will the public institutions because they lack ID, but it provides a wide range of services. Mobile health van gave urgent care, gave primary care, gave preventive care. It was able to uh, uh, connect patients to secondary and tertiary care, and it was able to provide services to the ailing, marginalized children. Now, this publication, this is probably the only one that I know in the recent history that which has shown a mixed method research published in PMJ by our group, and it would what this study has been able to add is that, and is also given some guidelines to the government to, we would like to work with you. The government needs to be more proactive for these needs of these 20 to 30 million children who are lying on the streets of our country. And we need to ensure that these children get quality care. And mobile health van is one of the ways of overcoming the barriers. And it provides them primary health services and also connects them for secondary and tertiary care services to major hospitals. Now, there are lots of government programs, and there are a lot of SOPs. One of the SOPs which came out in 2020 by National Commission for the Protection of Child Rights. This is for street children, and this is an excellent document, but it needs excellent implementation as well. The this graph actually algorithm rather shows that when a street child is produced in front of the Child Welfare Committee, which is a committee under the Juvenile Justice Act in one district of India, there is a one Child Welfare Committee, a set of 5 people who are very well informed of child rights, health, and welfare. These people then decide what should be a short-term care or long-term care, and what are the other family schemes, how they will do rehabilitation to if a child is using drugs or if a child has disabilities. So this is what the flow chart shows. The problem is that many children are still suffering, are unable to access care. And they continue to suffer something called adverse childhood experiences or ACEs. These are collectively huge, big public health problems because ACEs now is not just limited to an abused child, a neglected child, but it also includes key elements of family dysfunction and a child's social environment. ACEs can be operationally defined as childhood events which are varying in severity and often chronic. They cause harm or distress and thereby disrupt the child's physical and psychological health as well as their development. Now, street children particularly suffer a huge amount of ACEs. They are discriminated against, they're deprived of their basic rights to health, to protection and education. And this is a grave violation to the United Nations Convention of the Child's Rights, which we all have signed on. The ACEs, as I mentioned, they include not just abuse and neglect or violence, but if a child comes from a dysfunctional family or if the child comes from a poor socio-economic environment, they are really affected. Because what this trauma does, that it leads to toxic stress and it leads to epigenetic changes at the molecular genetic levels, and it can lead to high prevalence of adult onset diseases such as high blood pressure, coronary artery disease, diabetes, depression, and substance abuse. The Felleti et al. In 1998 showed us the ACEs study, which is very this thing, and it says that if a child is suffering right in early childhood, when they grow up, they will develop adult autism diseases. The mechanisms, physiological mechanisms through which the ACEs influence health is shown in this is chart. Yes, when there is poor physical and mental health outcomes, if the child suffers, it directly causes adverse consequences. Intergenerational transmission of adversities can lead to epigenetic changes, and there can be molecular studies which have shown that these children would have shortened telomeres and increased DNA methylation. And it also alters the immune systems of these children. They get more infections. So it leads to a vicious cycle, which also impacts the gut microbiomes. So this is a mechanism which is under right now more scrutiny, but pretty much the base has been established of how ACEs happen in children who suffer abuse, neglect, and exploitation and other kinds of adversities. Now, if you look at as pediatricians and as doctors, the red things that you see here on my slide here are the chronic exposure to toxic stress. If the mother has malnutrition, if the delivery is difficult with birth asphyxia, with a preterm baby or an intrauterine growth retardation child, if the child suffers inadequate stimulation, suffers from abuse and neglect and exploitation, if the child is malnourished, has multiple infectious disease, climate change, and all kind of chronic issues such as forced displacement, conflict, living in challenging and bullying and disabilities and various kinds of injuries. The red ones, it can lead to a lot of ACEs. The higher the ACEs, higher the prevalence of adult onset diseases. But we have opportunities to intervene through antenatal care uh, at the time of labor, childbirth, um, provide optimal breastfeeding, provide access to healthcare, safety from various infectious disease, and nurturing care, and uh, screening for non-communicable diseases, providing economic security. So, as pediatricians, we can do a lot of things to minimize and mitigate the effects of ACEs. Now, violence against children is a huge public health problem, and children who especially living on the streets, their health and well-being is jeopardized. They get multiple, like this slide can take hours, to just show, but I wanted to just show you that both it affects their communicable diseases as well as non-communicable injuries and a lot of mental health problems. Uh, Now, the United Nations has come up with this General Comment 21 based on UNCRC. It's on child rights approach to children living in street situation. So there's a shift from child welfare approach to child rights based approach, where the role of state parties in regulating and coordinating, and also the development of comprehensive child protection systems and capacity to build contact with the child and provide access to basic services such as health and education, protection, justice is extremely important. The WHO has come up with the End Violence Against Children initiative and the achievements of the Sustainable Development Goal targets by 2030. The ones that are very important and relevant to the street children is the 16.2, where it says want to end abuse, exploitation, trafficking, and all forms of violence against torture of children. The SDG 5 aims and preventing violence against all women and girls in public as well as private, including trafficking, sexual and other forms of exploitation, including child marriage and female genital mutilation. The SDG goal 8.7 uh, uh, deals with elimination of worst forms of child labor, including slavery, human trafficking, recruitment, and use of child as soldiers. And SDG 4 deals with safe, non-violent, effective learning environments and improving knowledge of the learners. So moving forward, we were able to establish a pre-conference workshop at the IAP conference in 2013 on optimizing health, well-being, and rights of street and working children. In that, we called for an urgent action for street and working children and their families to improve their conditions on the streets and and also for their families to ensure that every child and their families do not turn to street for their survival. Uh, the working group, a global consortium on a rights-based response to needs of street and working children has been established. And so far, the progress we've achieved is one is that pre-conference workshop at Gandhinagar. The other is the editorial, which was developed by Lancet Child and Adolescent Health. Then a special issue at the Cannes International regarding street-connected children in April 2023. We've currently established literature reviews and two scoping reviews on street and working children, their health and rights, and introduced a special collection at the BMJ Pediatric Open Work special collection on health and well-being and rights of street working children. We are establishing a framework for policy statement and training on child rights based approach to the health and welfare of street and working children. So I want to thank you all for your patient listening, and I want to acknowledge the support of Pricewaterhouse India Foundation for their support to BUDS for the mobile health van and some other 500 plus individual donors. Hope you join me again on this initiative. Thank you very much. हो गया सर.
Thank you very much, Dr. Rajeev Seth. But excellent
ये
talk,
आप कर लेंगे
excellent
आपके.
information
नहीं नहीं, थैंक यू सर.
to the
थैंक यू
audience,
सर.
and
थैंक
hope
यू सर.
that we will continue with a few more topics
डेफिनेटली सर.
related of
डेफिनेटली.
the working.
थैंक यू.
Thank you so much.
Thank you, sir. Thank you, sir. You have somebody who can join the tool, right? Or
Okay, okay.